Today we are going to embark upon a totally different kind of exercise. The slide that you see being projected here is part of a small, short presentation of only 4 or 5 slides, as a matter of fact, even less than that. And after that, then I'll come to the point that I that we are we get into that uh, exercise of uh, formulating something. Now, I think it's always good to sit back sometimes at various stages of your training while you are preparing for your examination, etc., and throughout the period of your training to ask yourself what were the objectives which you chose to do post graduation after your MBBS. Of course, becoming a doctor is uh, uh, there are reasons for people to become doctors, but once you become doctors, then there are specific reasons for you to become or to attain a postgraduate degree, because becoming a doctor can be sometimes influenced by parents or family and may not always be your own choice. But when you embark upon post graduation, then it is your choice. So, what were your objectives to do? You need to ask yourself. I actually prepared this only this morning, and I thought of a few things that you want to add to your qualifications. And that again begs the question that what for? Why do you want to add that additional qualification to MBBS? You love the subject. That means that you really like that particular specialty that you are in, obstetrics, gynecology, medicine, surgery, or whatever. But since we are within the fraternity of obstetrics and gynecology, therefore, why do you really like obstetrics and gynecology? Is it just a chance that you got into it, or if you really like it? And if you really like it, then that means that you must imbibe yourself into it, that you like it so much that you really love it. Another, of course, is that you want to be a lab-based doctor in quest to learn more and more that you wanted to do post-graduation. And another can be that you could be inspired by an event which stimulated you to get into post-graduation, or there may have been a person by who you were so influenced, or you were inspired by that person, that you chose to become a specialist and you chose the specialty, and that's kind of role model that you had. These are the questions that you need to ask. And in addition, of course, do you want are you so much interested into academics that you want to read more, you want to learn more, you want to do research, and there are so many aspects to academics. And another could be that you thought that there is need for uh, change. You want to improve things. You see that things are not doing or going well or going in the right direction, and perhaps by attaining that extra qualification, that training, you will be able to bring a change. And it is not something which is abstract. You can do it if you really want to do it. And the changes are brought by persons, people who start individually, and then of course they make a team or they gather support, etc. You want to make a name for yourself. You think that when you have another qualification, you become a specialist, then you will be recognized, you will be known, and you may want to have or attain a higher status, that you don't want to work as a medical officer only, or just a general practitioner or a family physician. They have their importance. Each person in the society at various stages and at various stations have their own importance, and they are part of the wheel which runs the whole system. So being a medical officer, medical officers have their own job. You can't do without medical officers. So, but you wanted to attain a higher status. You wanted to go into academics, like you become an assistant professor and ultimately a professor and whatever. So you go into that and earn more money. You think that by being a specialist, you will have the opportunity of earning more. Although you would come across many family physicians and general practitioners who make a lot of money. And as a matter of fact, in periphery, they have gone into politics, etc. They have amassed fortunes and etc. But one generally would tend to think that by being a specialist, you probably have greater opportunity of earning more money. Now, when you have asked yourself all that, then you also need to ask yourself what kind of a specialist you want to be. You want to be a knowledgeable specialist. I'm sure that most of you would want to be. You want to be a skillful specialist who has good skills. You want to be respected for your knowledge and skill. You would want to be a kind of a specialist who is well respected, who's sought after, who's brilliant, outstanding, and remains up to date with the things, who is innovative, who brings about new things, who thinks of new things. You are working in a place, I had a colleague who, I was senior registrar, he was registrar, and he did only MCPS, a male who did MCPS in obstetrics and gynecology and became a district specialist. He was posted at Sheikhupura. Although Lady Wellington Hospital is very close to Sheikhupura, it is only 23 miles, and people think of that as part of Sheikhupura. But still, being in district headquarters hospital, he in 83, 84, he established a diagnostic laparoscopy unit in the district headquarters hospital, Sheikhupura. So even at that time, in 83, establishing a diagnostic laparoscopy facility in that. So he was innovative. And then high achievers. You want to achieve many things. You want to attain a certain status. You want to achieve in terms of skills, in terms of academics. You want to become popular amongst the fraternity. So these are various reasons. So what kind of a specialist? A popular specialist, high achiever, up to date, outstanding, brilliant. But then also you need to also have these qualities. I'm sure that you would want to be a kind, compassionate, empathetic, and respectful person, and a specialist who is soft spoken, who is considerate and understanding of the others. Now, all these qualities would be required when you interact with your colleagues, with your juniors, with your seniors, with the nursing staff, with the administration, with the patients, with the attendants, with the support staff, wherever. So all these qualities, as a matter of fact, help you to become a better specialist and someone who's easy to talk to, so that people can communicate with you. You are a good communicator yourself, and people can communicate with you. And then, of course, there are some other qualities, like you want to be ethical, or you ought to be ethical. You want to inculcate a faculty of being methodical and meticulous, punctual, presentable, neat, well dressed. These are some of the qualities, and you may add quite a few of those to all these. This is something I want to emphasize, that if you want to be, you need to have or try to attain some of these qualities. Now we come to the postgraduate examinations, clinical examinations particularly. And this all started actually from there. Now, in clinical examination, the candidates, they take history, they present history. And when they present history, mostly it is good. You would find difficult to find it difficult to point out major mistakes. So generally, history is good. If someone is not good in history, we shouldn't probably, or they shouldn't be taking the examination in the first place. When it comes to physical examination, usually most of the candidates are usually okay. And then investigations, that too generally is okay. Although if the time management has not been proper, then you would miss out on some things. When it comes to the next, which is counseling, when the management starts, and the management starts at some place in the counseling area, suddenly you start, the candidates falter. They don't know what to say, what to start, where to start from, and where to go, and what are the points which need to be highlighted, what is the kind of language, phraseology that you would use with the patient or the attendants. And particularly if it's an unpleasant situation, then what do you do? And finally, then making difference is the management thing, because that's part of, once you falter in counseling, then the rest of the management also is uh, something that probably you wouldn't be very comfortable with. So this is, I thought, the situation. This is the problem. And faltering in the examination, why does it happen? The reason for that is that we tend to forget what we read. If you read once, twice, thrice, 4 times, you would remember quite a few things. But then if you are not practicing that, then you will uh, tend to forget after a little while. It is not that every time you kind of uh, uh, remember it by heart. You can't. There's no way, and there is no desirability of that. But there are things that if you do repeatedly, that of course that becomes a kind of habit that is inculcated and incorporated within our reflexes. So that becomes a habit. And then it is when you are confronted in the examination with that kind of situation, which you have dealt quite a few times, you have done it many times, you feel comfortable with it, you feel at home, and therefore it is a matter of routine for you to reproduce all that. And generally, what we do is that we read the book, we read the guidelines, but we are not practicing it. We don't follow them. We read them only to remember for the examination. Once we've passed the examination, then we are lost. We don't refer to them. We don't bring them into practice, and that's why we don't remember that. So, from the point of view of a candidate, if a candidate goes through a system where those guidelines, the practices written in the book, they are actually practiced, then imperceptibly and gradually, with the passage of time, the candidate may not even refer to the book and would know how that condition is to be managed. You look at, for example, abnormal uterine bleeding. Now, if you have a set of guidelines, if you have a set of uh, uh, protocols for you, that if there is abnormal bleeding in teens, what do you do? How do you approach that? And within that unit or where you work, where you are being trained, if there is that, I would divide abnormal uterine bleeding into 3 age groups, let's say, if you can do that. One in teens, second is reproductive years, and third is after, say, the age of 40 or in the later part. And then fourth, of course, would be postmenopausal abnormal bleeding. So if you have a framework of how those conditions are being managed, and that is you follow time and again, and that is a matter of routine for you to do that, you then would refer to the book only to see if there is anything new or if there is anything which you are not practicing and that is given in there. And then there can be two things. Either you would then incorporate that in your practices, or you then would question whether it is appropriate or not. But once you do that, then that's a matter of routine for you. And therefore, actually, we have 3 kinds of practices. One is what we read in the books, what we read in the guidelines, and then what we do in the public hospitals. Because there is lack of resources, we cannot have there is a problem with the availability of those perhaps gadgets, instruments, or facilities, or there is paucity of funds. We don't have resources, and that's why we cannot practice that. And that's why that question comes in the examination, that what would you do under your circumstances? Or when you say that I will undertake this particular investigation, and then the examiner asks you, do you have this facility in there? Do you do it? Do you practice that? So that's important, that if in the public hospital that facility is not available, then what do you do? And thirdly, of course, when you get into private practice, then probably there are other considerations because of which the practice usually changes. But if within a unit or within an establishment of obstetrics and gynecology, if we have laid down methodology, rules, or guidelines or protocols to deal with certain common conditions, then that would be helpful uh, uh, for everyone, because that's why the topic for today that we were going to discuss amongst ourselves, but then I thought that we'll include all of you on Zoom as well, so some of you might get interested in that. You probably may do it in your own spheres wherever you are. So we actually today we have gathered for initiating uh, an exercise of formulating protocols for the common management situations. And we can start with just the management of labor. As a matter of fact, this is a question which is generally, or this is the area which is generally not discussed in the examination. But I used to be quite fond of discussing, if I had time in the examination with the candidates, third stage of labor. And I would ask, how do you manage the third stage of labor? Active management, passive management, etc. What are the ways of doing it? Why do you do that? Etc. So those are the common things that we do, but we just forget to pay attention to the details. So the protocols are important for the trainees to follow, so that they practice the guidelines, and they bring within their sphere of activity the good practices which would be acceptable not only in the examination here, but if they intend to take examinations abroad, even there. And also that will help them become better specialists and better consultants. And also, it is equally important that the patients also deserve better, that they should be dealt with, or they should be handled and treated according to internationally recognized protocols or guidelines. So that's the reason that we all started. Number one, why do we want to become a specialist? What kind of a specialist we want to be? And if we are specialists, then how can we help ourselves pass the examinations and also the various practices? So there we start, and I had asked actually the residents here in at Hamid Latif Hospital that we would want to initiate this exercise of developing protocols of the common things, and then of course if we accumulate, and I would very much welcome your participation in that. You can write to us, you can send your proposals, you can send your suggestions to us, and when we finalize any protocol, we will then put it up for all of you to go through that, and you can suggest changes in those as well. Actually, we started with the common things, which is say labor protocol for labor, and in even labor, let's say the first stage of labor. And when we start looking at that, the first stage of labor, we started looking at how do you actually receive the patient. If you or a relative is a patient and you reach the hospital or a maternity unit, then how do you want to be treated there? How are you received there? How things proceed with you? We have a very nice labor room established here at Hamid Latif Hospital. It's a kind of a modern facility, and we have a good number of staff, very efficient and very uh, keen doctors. But if we look at the details, probably there is a lot of room for improvement. Yesterday, we went through a small exercise in which we asked our nursing staff, how do you handle the patients? So starting with that, receiving the patient, then conducting the patient, then the history, etc. My objective would be to formulate various protocols which are comparatively short, but which are more in the form of a kind of a checklist, that have we done this, have we done that, have we done that. Not necessarily a checklist in that sense that you take off those things, but reminding you of those things. For example, if you from here develop this habit of introducing yourself to the patient, that I am Dr. So and so, I'm going to take your history and I am going to examine you and see where you are, and then we'll decide about the management and we'll discuss that. Now, when you do that, that becomes part of your habit. That becomes part of your routine. That this is how you approach the the patient. So in the examination situation, that is exactly what you will do. You will introduce yourself to the patient, and the examiner will not have to point out, did you introduce yourself? Or when you take the history, then you also go through those various areas of history and interaction with the patient. Now, if you are doing that and considering that you are following that system, then after that history, examination, etc., you establish a routine for yourself. And after you complete the history and the examination and you go through the record of the patient so far in the pregnancy, then you would say that, yeah, well, these investigations are required, or this is how we are going to manage. You will communicate with the patient. You will give a short brief to the patient that this is what has been observed, that your pregnancy has been uneventful. It is a normally going pregnancy, and you've been uh, planned to have a normal delivery. And for that, now you are in early labor, and this is the stage of labor. And at this stage, this is to expect, and this is what will happen. You can be in the bed, you can be up and about, you can eat, drink, not eat, drink. You will have intravenous line or not line. You will have some drug placed inside the lower birth canal or the vaginal canal, or you will be given a drip, or your membranes have ruptured, or your water bag has ruptured, and this is what it entails. So that kind of information, when you communicate with the patient, you tell them, you reassure them, and that is how gradually you learn about the counseling. So you know how to counsel the patient in that given situation. Or similarly, if on the other hand, you take into account a patient who is bleeding, who is pale, who is semi-comatose, who may not be responding, or a patient who's come in climactic fits, then what do? Now, what is the first thing that you will do? And if you are delivering a patient and she suddenly starts to have bleeding, there is PPH. And then what do? So what is the first thing? What is the second thing? And who will be doing what? For example, in a case of, say, eclampsia, or in a case when you come across, the first thing is that you shout for help. You don't call for help, you shout for help. So express it like that, shout for help, because that totally changes the connotation of that call for help, actually, that you are in desperate situation. So you shout for help. And then what do? There are more than one things that those are being done. For example, a patient who was having an eclamptic fit, she is being catheterized, an IV line is being secured, and someone is also taking a short history to ascertain what kind of fit that may be, whether how long is her pregnancy, booked, unbooked, what kind of. So history is being taken, IV line is being secured, urinary catheter is being placed, and you also give a certain drug, you call for help, etc., whatever. So there are so many things that you will be doing simultaneously, and you don't do that only yourself individually. That's a team that will be doing it. So you gather that team, and therefore you will establish some protocol of alarming or shouting, or who will respond to what kind of that shout, that anyone who is within the hearing range, and who will be called, etc. So then that also answers the question that in that kind of situation, what will you do? And therefore, this is what my idea of starting this exercise is. You can come up with your ideas. Now, to begin with, I looked up on the net and I tried to find some protocols. And for example, I've come across this one. This is the labor care guide. This is the longest one. This is of University and National Health Service of UK. Why I am looking at this UK thing is that most of us, mostly in Pakistani hospitals, UK the protocols or UK system is followed because most of our senior specialists earlier on, they were trained in UK and they came here and they established facilities here. So I am also looking at this. This is the labor care guide. It spans 42 pages. We need not have 42 pages. Uh, we can look at those areas which really relate to this. So we'll be looking at, for example, this on admission. I will enlarge it a little bit. On admission, first labor contact, for example. Listen to the woman's story. Consider her emotional and psychological needs. You see, we generally tend to treat our, and now this is not only in private hospital. This is something, if you look at the new guides of WHO about labor management, you would come across a word repeatedly, and that's, though that phrase is respectful maternity care. Respectful maternity care. And those guides are actually written for developing countries, for areas where the facilities are not adequate and enough. And in our hospitals, do we really look at that? Consider her emotional and psychological needs. Review. Now comes the review. And no, this is one way of looking at things. So this is how we actually develop the our protocol for management of, say, a patient who comes at term with labor pains, right? And so first is receiving the patient, interacting, and then diagnosing that the patient is in labor or not, and what stage of labor, what kind of labor. It's latent stage, it is active labor, and admission, no admission, etc. So that's how we want to proceed. And I would want that you can make it that you take vitals, for example. You don't have to put it pulse, blood pressure, temperature. They can be put in one line. What tests will you advise? Why urine analysis, etc. So assess maternal well-being, assess fetal well-being. So this is part of history and examination. And then what you do. So this is my brief on what we want to do and how we actually would go on to develop. And I hope that some of you would get interested in that, and you would participate in this exercise of ours, because we would not necessarily every time that we would only be talking about a protocol. We will be talking about other things, but this is something that we are starting. We will be working on that, and within our other time, we will be preparing one or two protocols every week. Once we start with that, then of course we'll continue to polish them and improve upon them, right? Now, if there are any questions, there are any comments, please feel free to make. मैंने आपके लिए पहले एक वो किया था, कौन सा? इसमें अगर आप देखोगे, ये आपको मैं कर दूंगा, ये लेटेंट फेज ऑफ लेबर की बात आ गई कि उसमें क्या है, वो तो वो डिस्क्राइब भी करते हैं ना. It is not only what you're doing, it is the whole. When we are managing a patient, we are not describing all that. That's a different part. We'll remove that. Established first stage of labor. Now, we don't have to define it in our protocol. Now, it's been established, and that is something which is separate. Duration of labor, etc. Assume normality unless proved otherwise. Ensure privacy and confidentiality. Use positive, empowering language. Now, these are the things that you will be practicing. You don't say you use empowering language. So that is not part of that. That is an attitude. Encourage the woman to empty her bladder every two. So this will be care of bladder and bowel. Generally, it is said like that. Care of bladder and bowel in labor, which would mean that if she hasn't passed urine herself, or you ask, inquire about every 2 to 4 hours that have you passed urine, and if she hasn't passed urine, then you catheterize her. Or if she finds it difficult to pass her urine, and you also palpate, because a full bladder is an impediment to progress of labor. Similarly, if there is controversy about it, now what is going to be our policy regarding giving an enema or not? What is the use of enema being given in the early part of the first stage? Or do you give it? Or do you give it, or under what circumstances you don't give it? For example, some people wouldn't give it if the membranes are ruptured, for fear of contamination from enema going into the birth canal. So those are the areas that you will have then reason for doing something that you want to do. So, and then of course you take recourse to other guidelines from NICE guidelines. ऑलराइट ये उन्होंने कहा जी कि लेबर रूम मैनेजमेंट का ये पीडीएफ, ये श्योर आई ये तो है जी इनका, मैंने जिस तरह से दिखाया, ये है यूनिवर्सिटी हॉस्पिटल ब्रिस्टल का, ये है, ये जरा लंबा डॉक्यूमेंट है, obstetric guidelines 2000, because these guidelines, they continue to get updated. And even if you look at these, which are about 2 or 3 years older, these comprise many of those National Health Service areas, actually, Southern Western Midlands, etc. Those are the areas where now these are practiced in so many hospitals, actually. And here is a list of various things. For example, in diabetes, antenatal diabetes, labor, 3 pages. That what specific measures you take in diabetic labors. There is, of course, a good amount of emphasis on documentation. Now, we don't want to have a 288 page. This is whole. This is affecting all different types. We want to have a shorter version of that. And that is something which is now, we are not immediately concerned with anemia. When we get to that, we say that, of course, yes, if there is anemia in the, what do you do? So you give oral iron, or, but anemia is not in those scale areas. That's different. This is a very lengthy and comprehensive thing. Now, this is induction of labor at Guy's Hospital. This is only a 6-page. That what do you do for this? This is a leaflet for the patient, and from that you can actually make a protocol for the hospital. That because the patient would be expected, she would be explained that this is to be expected, and this is what does labor, when does labor normally occur. Now, this may not be the part of your protocol. You would say, when would you induce labor? So you'll give indication. So what you will do is that when you are to induce labor, you will check, is there an indication for induction of labor? Genuine indication. So you will check that. And if you find that there is not adequate reason, you can contact the consultant. You can call back. You can say that this is the patient, this is her situation. Do you really want me to induce labor? And so you identify the indication. So what is induction of labor and why I am being offered it? Now, there is prolonged pregnancy affected by medical condition, obstetric cholestasis, blood pressure, diabetes, multiple, etc. So whatever. So indication for induction. Can anything help bring labor on naturally? What can I do? So are there any means? How will I be induced? These are various cervical ripening. How is it done? So, what is the protocol in Hamid Latif Hospital of ripening cervix? Do we give prostaglandin pessary and send the patient home with what kind of instructions, or do we keep the patient in the hospital? So, there is now a condition or a protocol called as ambulatory ripening, which means that you give that and you send the patient home. So, how do you ripen the cervix? What preparation do you use? What is the dosage of that preparation? What form does it come in? And then artificial rupture of the membranes, intravenous drip. How long does an induction take? So if it prolongs, and because this is important, that and this is part of the counseling that you will be doing to the patient, that you tell, are there any risks for induction of labor? This again is to be discussed with the patient. What pain relief can I have? What happens if my induction does not work? What are the benefits of induction if I am overdue? How will I be induced if I had a previous cesarean section? When will I come into hospital for my induction? Why might my induction be delayed? Can I have someone with me? What if I decide not to be induced? Now, this is a 6-page leaflet for the patient, and from here you will take cue and you will prepare. So when you start making your protocol of induction of labor, you will look at the indication, you will rule out contraindications, you will assess the maternal well-being, you will assess the fetal well-being, then you will carry out examination and you would do a Bishop score, and according to that, then you will either cervical ripening, or you would say that if it is tubular long and its cervical Bishop score is only 2, then you would say that well, we are going to only ripen your cervix, which may take 24 hours or even longer than that. And for that, because the patient comes with this state of mind in her thoughts, that when she comes to the hospital, something will be given to her, she'll go into labor and deliver within 12 hours to say 24 hours and go home well with the baby, which is not the case in situations when the cervix has to be ripened. Then, well, it will take more than 24 hours sometimes, and that's why the patient should be briefed earlier on beforehand, that if the cervix isn't ripened, then you will require another dose of that, and which can be given after an interval, and it may take a few days. So that kind of counseling is required. ठीक है जी. और इसके अलावा ये है गाइस हॉस्पिटल का. एक ये इंडक्शन ऑफ लेबर का इसी तरह से है, सेंट जॉर्जेस हॉस्पिटल. ये 8 पेज का है. 8. It explains a few things. This is again the leaflet for actually patient, which explains about midwives and doctors. We unfortunately don't have that cadre of midwives who would look after the labor. Now, some of you may get this idea of training midwives in your units, which actually is our responsibility. If we do that we train midwives in management of labor, even in conduct of deliveries. So, if you combine both these induction of labor things, then you can have even some diagrams to explain to the patient. If you have it readily available in that document of yours, so you can tell them that this is what we'll do. And they use Foley's catheter a lot in patients in whom they don't want, for example, patients with previous cesarean section whom they want to induce. They wouldn't use prostaglandin or uterine stimulants. So Foley's catheter will be passed into the cervix and it will be dilated a little bit and the patient will be sent home. So you come if the catheter is pushed out or if the labor starts. So these are this is again just about a 8 page document. So you can take these, and from that you develop the protocol for. This is another one. This we already have. So this labor care guide, this is again this is the labor ward guideline again. I'll put these documents on the. So you make 2 teams, I would say. One works on management of labor, first stage, second stage, third stage. First stage is more important. First stage and second stage are more important because in that there is longish management. The final part of the second stage and third stage, those are actually the skills. That's part of the skills. But early part of management of second stage is when do you shift the patient to the delivery room? When do you put the patient in lithotomy, or do you really put the patient in lithotomy? What different options would be available, which we do not exercise? So that kind of thing. Right, Ji, any questions from the participants on the virtual meeting? आप लोगों के कुछ suggestion questions? भेज देता हूँ आपको. Okay. Right. Thank you very much. जी हैं?
टॉपिक्स सर कह रहे थे उनके पोस्ट ऑपरेटिव केयर एनेस्थीसिया मैनेजमेंट उसके जो टॉपिक्स थे.
एक मिनट में आता हूँ उस तरफ. ये तो नहीं है ये.
नीचे ज्वाइन वाला.
हाँ, यहाँ पे खत्म कर दूँ. ओके जी, खुदा हाफिज. सी यू नेक्स्ट वीक.